Okay, so intracranial hemorrhages, you can think of them ICH, but that's actually already taken by intracerebral hemorrhages, which technically are your hemorrhages that happen within the cerebrum, right? So intraparenchymal and intraventricular hemorrhage technically are also ICHs. So it gets a little bit confusing. So you just got to make sure you're reading as intracerebral or intracranial. It's like, well, it's in the brain. Okay, within the skull. But these are different ones we'll talk about next. We're talking about epidural and subdural hematomas and what the difference is between those. We've talked about subarachnoid hemorrhage. We'll do a quick recap on that. As we know, it's aneurysmal. We're talking about traumatic damage, right? So aneurysmal is due to what disease process causes aneurysmal ruptures and subarachnoid hemorrhages? That was due to unregulated what? Hypertension, right? But this is now we're talking about due to a trauma of some sort, right? So subarachnoid hemorrhage, intraparenchymal hemorrhages also were due to hypertension, but basically if you get hit in the head, any part of the brain can bleed, right? And then that intraparenchymal hemorrhage can extend into the ventricle system and cause intraventricular hemorrhage, right? So that's the idea behind our different intracranial hemorrhages. Okay, technically these are hematomas because they're a collection of blood, but I mean the difference is like very loose. But epidural and subdural hematomas are commonly compared and contrasted, and we'll compare them. We have a whole slide that compares them and discusses the anatomy. But basically, knowing your anatomy again, you got your skull right there. Right, the periosteum is on top of the skull. That has nerve fibers on it, so that's usually the part that hurts the most when they drill into the skull with like a ventriculostomy. But there's no pain fibers below that point, right? So next step that's sitting right up against, it's like tacky right on like wallpaper. Nothing is there besides what? Besides arteries, right? So arteries are between this layer right here of meninges, this layer in green right here. And what's that layer called? That is our dura mater, right? So our dura mater means tough mother, right? So I'm a dura mater, right? So it's tough mother is the first layer, our first meninge, if you will. Okay, and then under that we have the what? We have the arachnoid mater, right? So between the dura and the arachnoid mater, or the spider mother, is what that stands for, right? So we have the between those two are our veins, right? So you notice here we follow that green line, right? So underneath that dura is a subdura hematoma or subdural hematoma. Okay, so if you notice what goes in between each one, so arteries are between the skull and the dura, and below the dura and between the arachnoid layer is your subdural space, or it's not really a space, it's like sandwiched veins inside, right? We have a better picture coming up when we talk about subdural. You can see that it's literally veins are sandwiched in there, right? And then below the arachnoid space, right, and the other nice little thin saran wrap that's on top of the brain right there, okay, is a subarachnoid space. So we have the arachnoid layer and the pia mater, right? Pia, I forget, I think it means like thin mother or something, I don't know. All right, so it's or like devout mother. All right, so it's these are the different layers, and it makes sense. We've been talking about the subarachnoid space where subarachnoid hemorrhages develop, right? And then, of course, above the subarachnoid space, it's bound by the pia and the arachnoid layer. And above the arachnoid layer is really, there's no space there, but in that sandwiched in between these two layers is our veins, right? Our subdural space technically, but it's our veins are there, and when they rupture or when they get broken, now you're going to start getting a subdural hematoma. And then upon that, upon the dura, or epi means upon, right? So epidural layer are our epidural bleeds. Okay, so we'll talk about those. Above the dura, below the dura, is it arterial bleed or is it a venous bleed? Which one's worse? Arterial bleed, right? They are very, very sick patients. Are they sick as like a cerebellar hemorrhage? It depends, but epidural hematomas are very, very significant. They need emergent surgical evaluation to remove the epidural hematoma. You don't just wait on epidural hematomas. Subdural hematomas you can wait unless it starts causing herniation. Then you're not going to wait anymore. It's like, oh, I'm pushing down on my cranial 3 now. I got oculomotor dysfunction. My pupils aren't working, right? Their eyes are deviated towards the injury, right? So in this case, the eyes would deviate which way? The left, right? So left and right. Okay, or sorry, or do that backwards. All right, so you get your, I'm thinking of CT scans, but you have, because CT scans throw SAP out the window. But we have our, there's our left side, there's our right side. Okay, so we have a left-sided subdural hematoma. Their eyes are going to be looking towards the left, where the injury is. Does that mean epidural hematomas can cause the same thing? Yes. So the epidural hematoma is growing and growing and growing. It can cause compression and herniation of different structures. All right, so just a recap on subarachnoid hemorrhages, right? There's different types. There's aneurysmal and non-aneurysmal. Non-aneurysmal, what is it called? Subarachnoid hemorrhage, right? Like NASA. But basically, you have aneurysms is pretty common, but you can also have ones that are due to trauma, right? So aneurysm also we talked about already, and trauma can make it happen as well. It can make your aneurysm burst that you never knew you had, right? And then the scary thing is that now you're waking up at night looking at your petechial hemorrhages, and you're looking at deep sea divers on your phone as well. And then you could just be sleeping, and then you could have a rupture of your aneurysm. Right? That's the most common time it will like to rupture. Right? Because during the nighttime you have your circadian rhythm, you have cortisol being released, you have a little more stressors happening, and then you have dreams, and you're like running away from a deep sea diver, and then it's going to cause some problems. Yes. So you have a no sleep to avoid prophylaxis. Get subarachnoid hemorrhages. So what are the symptoms again? We said it was the worst headache ever. They say it's a thunderclap headache, a thunderclap headache, and then it causes that meningismus as all this ruptured aneurysm, irritates all this stuff here. The SNS fiber is going to fire down and are going to cause Takotsubo cardiomyopathy, right? A little picture of an octopus again, right? So usually it's a anterior dilation of the ventricle, of the left ventricle. And if you look in Japanese, what a Takotsubo looks like, right? So it looks like a octopus container at least. Okay, so what else on that? So you have those symptoms can occur. You get those cerebral T waves we mentioned. Okay, and then you can have your heart can just straight up fail. But and you get the neurogenic pulmonary edema. The heart can't pump the blood forward. It's going too fast. All the fluid starts backing up. It's either going too fast or it's failing, and that could cause a neurogenic pulmonary edema from that ruptured aneurysm, right? And we get our Death Star appearance, and we have a subarachnoid hemorrhage. The same thing can happen with trauma, right? Trauma can rupture the aneurysm, or trauma can just cause a rupture of the circular Willis, right? And now the circular Willis is involved, right? Over here we have this rupture of that, this portion of the circular Willis, the communicating artery, and now the blood is filling up in those spaces. It's filling up those little cisterns and valleys, right? And we can see that on the CT scan, and we can see the different valleys that are filling up in front of us. Okay, and then we mentioned that the CSF needs to get reabsorbed up top right here. So here we have the top. We have little arachnoid villi that are going to absorb the CSF into the sagittal sinus, the big vein at the top of the head, and that's going to then hopefully the CSF will have good outflow. But if it doesn't, because of blood that's going to be in here and make its way up there, clogging those pores, it's going to then cause what kind of hydrocephalus? Communicating or non-communicating? It might be opposite what you think, because it's not communicating, right? How's this? Which one is it? All right, so it's communicating because it is, we don't have a problem in the inside. We have a problem because it's communicating fine until it got to the outside. So it's technically a communicating hydrocephalus. Okay, so we've talked about the complications already, all the different vasospasms that can occur. Right, as we compress the MCA, we know the MCA feeds the face and the arm. We know it compresses the ACA, vasospasms on the ACA. We're going to have some, wet, wild, and wacky. If we compress the PCA, we're going to have some cortical blindness, and we might have some, cranial 3 activity, dysfunction, and these guys can be a little altered as well. Okay, so we talk about meningismus as that blood started being broken down in the CSF. It's going to start causing, the xanthochromia and LP, but also it will start to be at risk for meningeal signs, right? What are meningeal signs again? The same ones for meningitis, except there's no fever with this one. Meningismus. You got photosensitivity, nuchal rigidity, right? You got Brudzinski's and Koenig's sign. You have all these different, the classic things with meningitis. And also, is ALOC there? No, we're talking about like the meninges itself being irritated, and it can make you not perfectly alert. Okay, so that's the idea behind non-aneurysmal versus aneurysmal, and we talked about that back in with hypertension. All right, so epidural hematomas. So epi means upon, so it's upon the dura. As we mentioned, the dura is what's sealed up against the skull, only making room for the arteries that might be running through there, right? That's the only thing that's running through this piece here. So here's our little, that's a little bit stretched out. I wouldn't put a space there. But they have so you have these arteries all just sitting right up against the dura, right? Upon the dura, I should say. Against would kind of mean under, right? So it's above the dura. So it's epidural, and it's going to cause this arterial bleed, which is going to start pushing and pushing and pushing. And what shape is that? Is that convex or concave? That's a convex, right? If you go into a cave, right? This is a cave. That's a not cave, right? So if you're going to walk into a cave, that is called that's a concavity. But convex is where you have a outward appearance, right? So we have a convex shape here. They call it a biconcave because it's going outward and it's going this way as well because it's growing and growing and growing at an arterial speed, right? So these guys usually they have a loss of consciousness. They get knocked out because they got hit in the head or they have some kind of trauma, and then they wake right back up and they're perfectly lucid. They got all their faculties. They're completely alert and oriented times 4, no deficits at all, just maybe a headache where they got hit, and then now they are dead. So because of that how fast that arterial bleed is spreading. Okay, so it's a talk and die is the mnemonic for a patient that has epidural hematomas. And this rapid change in the increased ICP, as you can see, it's spreading, spreading, spreading. It's going to start compressing all these structures and causing uncal herniation, for instance, right? Compressing down onto the brainstem. And we mentioned the pterion bone. That's the thinnest bone in the skull. And the way it was designed right above an artery. It's the middle meningeal artery that runs right over that, or I guess under that bone, right? And that's of course upon the dura, and that's going to then cause a epidural hematoma, right? So they have that lost consciousness, they regain it real quick, and then they are dead because of the arterial speed at which it bleeds. Okay, and then of course your ICP is going to go up as you start herniating. You get your Cushing's triad developing as we have this rapid increase in ICP. Okay, ICP. So that's the idea behind epidural hematomas. You got this middle meningeal artery running right past that thin piece of bone, right over the temporal bone. All right, so again, the arteries are up against the cranium, right? And then we just kind of seal it in place, like vacuum seal it, right? And then that's going to seal up, that's the dura mater that's sealed up against those arteries. And right there, that was the pterion. That's where we have the thinnest part of the bone that can easily get fractured if someone gets hit right there. Okay? So what else about that? So the other cool thing is like it's not cool, but when someone dies, you see the skull, right? You see the skull, you can see the arterial impressions in the skull because how close it is to the skull. The skull kind of grows around the arteries. Okay, so it's an arterial bleed and it's convex on a CT scan. You can see here this huge white formation that's getting more and more convex, and it's going to keep pushing and pushing and pushing. Right? I said epidural bleeds are arterial or venous? Arterial, right? And subdurals are venous, right? They're not going to be pushing. And there are big ones that can push, but most commonly they are going to be kind of just following the course. They're going all the way across, and they are filling up all the spaces, kind of like our subarachnoid hemorrhages, but this is more at the top of the brain in our subdural hematomas. That's usually where most of our traumas occur, not at the base of the brain, right? So the other piece on that is, again, subdurals are venous, epidurals are arterial, and the dura, right here, the dura mater, it doesn't pass suture lines, which is another characteristic of epidural versus subdural, right? So it doesn't pass when our dura is glued together here, it doesn't pass the suture lines. So it's going to keep growing and growing and growing. It's going to stop at the suture lines. It keeps growing, whereas subdural can pass suture lines. Okay, there's another unique feature of epidural versus subdural. Hmm? A and E what? Oh, the vowels for what?
To remember it?
The vowels affect what?
No, like epidural and arterial.
Mm-hmm.
The A, the
True. Yeah. Venous subdural and so vowels of A and E. So arterial is an epidural bleed, and a venous bleed is a subdural. So you got vowels and consonants. Good. All right. So moving to subdural hematomas. Right. So subdural hematomas are ones that are venous bleeds. So our vein has ruptured, or vein has torn with a trauma, and that bleed is going to cross the suture lines. Right. It's going to keep growing and growing and growing, and it's going to keep push. It's going to eventually start pushing the brain in, right, as that increasing mass occurs. And the key thing about this is that it can be acute, just like an epidural hematoma, or it can be chronic, where they have the chronic hematoma and then it kind of heals itself. They might have had a headache for a while if they felt the ladder for Christmas time, and then they took the lights down after Christmas on January 1st. They fell again, right? So now they have an acute on chronic subdural hematoma. Right, so the subdural hematoma was there already, and then it kind of coagulated, and then we have another hematoma on top of it. So you call it like a crescent sign, is or hematocrit sign is a sign of a acute on chronic subdural hematoma. All right, so there are non-traumatic kinds. That's where you have like Alzheimer's disease. Your coags are off. I mentioned warfarin is classic for intraparenchymal hemorrhages. It's also classic for subdural hematomas will develop. Okay, so we have this subdural hematoma. You notice it's kind of getting convex there, but it is not convex, right? It is following the portion of the brain. Okay, so here we have a contra coup injury where we're hitting the back of the head right here, and then that's going to cause a damage on the other side, right? If it doesn't cause a bruising or contusion, it can cause a hemorrhage to form, right? So what else? So brain atrophy is a significant cause, puts a significant risk factor for a patient to develop a subdural hematoma. There's that crescent sign I was looking for before, the hematocrit sign. But going back to brain atrophy, now all the brain is kind of being pulled inwards with atrophy, and it's going to start tearing on the veins that are being held there. There's specific bridging veins, which we'll show on the next slide. And now you're at risk for just one little fall, and now you have a subdural hematoma. Okay, and of course we mentioned acceleration injuries, coagulopathies with warfarin and other anticoagulants as well. And if that were to happen, to prevent the subdural bleed to get bigger, what would be given? If you want to fix it tomorrow and it's warfarin, you would give vitamin K, right? But if it's an acute bleed right now, it's causing change in mentation, yes, you would give PCC, right? The brand name is Kcentra. Okay, so it's going to, yes, you will start compressing local structures and you'll start increasing ICP, causing herniation. So we have this subdural hematoma that's developing here. We also have a skull fracture as well in this patient. Okay, so we can start compressing things and start taking all the things we talked about before with herniation, all the similar symptoms. So here's the anatomy that I was mentioning. So here we have our sagittal sinus that goes across the top of the head. And then we have this little bridging vein right here. And that's going, as our brain starts atrophying, that's going to start pulling everything with it, right? So as the brain starts, pulling all the way down, all the bridging veins are pulled with it, and they can just spontaneously hemorrhage with someone like an Alzheimer's patient, right? That's that cerebral amyloid angiopathy, right? That's the amyloid plaques are literally, causing dysfunction of the brain, and they're eventually going to atrophy, and it's going to pull the veins with it. Specifically, that bridging vein is a common place for subdural hematomas. Like if you had to bet where a subdural hematoma is going to be, it's usually going to be at the top region up there. Okay, but you can get it at the frontal lobe if you have like an injury or a fall on their head, on the back of their head, for instance. So this bridging vein is getting torn, and that's what's causing our problems. If you notice, like an Alzheimer's brain looks exactly the same as an alcoholic brain at 43 years old, which is interesting as well. So alcoholics are at high risk for subdural hematoma as well, especially, are they the best walkers? No, their gait is impaired as well. Okay, so Alzheimer's, atrophy, ETOH, these start getting pulled, right, with the atrophy, and these are upon the dura or below the dura. Here's our dura. We peeled it up and sandwiched between the dura and the arachnoid layer right there. So we got the arachnoid space, which is made because of the what is it? Where's a better picture here? We have our different spaces here, right? So we have our pia mater, we have our subarachnoid space, and then we have our dura mater, and then right underneath that, sandwiched between there, we got our veins. Okay, so we have our sagittal sinus up top, we got our different veins there, and of course the bridging veins are connecting with that sagittal sinus. So that's the idea behind subdural hematomas. All right, so again, a little summary slide on subdural, epidural. Epidural in red, right? They are convex or concave. What are epidural hematomas? They are pushing outwards, right? They say they're like a lemon as well. And there's our valves, right? So we've got valves, our E's and our arterial. The middle meningeal artery is that artery that runs right over the pterion, right? So most common cause is a skull fracture to the middle meningeal artery. And yeah, the pterion is the most common fracture, but you can get it elsewhere. As long as that'd be an arterial bleed due to a skull fracture or due to a trauma of some sort. And again, it's very, very acute. It happens within 6 hours. There's no such thing as a chronic epidural hematoma. It's an arterial bleed. So they have that rapid decline, right? So they're altered first. They're lucid. They have a lucid interval or a lucid period. And then they have a rapid decline to even being dead on the next evaluation. Right, and this requires surgical evacuation. There's not something like we're going to watch them and we'll take them to surgery in the morning. That's an emergent a neurosurgical emergency that needs to be resolved immediately. Okay, is a subdural hematoma an emergency? No, unless they have neuro changes. Right, if they have symptomatic neuro changes, like a pupillary change, got patients more decreased LOC based on when they came in or when I started my shift. That's someone that probably needs to be call neurosurgery. Should we go to OR to get this patient evacuated? And they say no. Let's go do a CT scan right now. You do a CT scan, it may be the same or maybe worse. That's why we're doing the neuro checks frequently to look for any kind of worsening herniation symptoms, right? And also on CT scan, we mentioned it crosses suture lines. So it's crossing all the way across these suture lines compared to the other one. The other one is locked in at the suture. That's where the dura is kind of stapled in on the brain. All right, so then what else? We have our different varieties of subdurals. There's acute ones and acute on chronic. You see how we got one bleed there, one bleed on top of it. We got the crescent sign, which is a sign, or a hematocrit sign is a sign of a chronic subdural hematoma. And then they also describe subdural hematomas as lemons, right? It's because concave convex is tough. So you get lemons and bananas. Did I say lemon? That's a banana. All right, so you got bananas and lemons. All right, so the banana is going to be a more concave shape, right? It follows the structures of the brain. All right, so this one up top right is what? An epidural or subdural? It's a subdural, and this one is looks like a ghost space in there, but it looks like that's a concave, right? Sorry, concave or convex? Which one? You're like lemon. Okay, so intracranial hemorrhage, again, it's the same stuff we did for subarachnoid, same stuff we did for hypertension, same stuff we did for ICP even, right? Make everything normal and make sure the blood pressure doesn't get too low, right? That's basically what we're doing, okay? So get a CT scan and neurosurgery involved so they know if we have to go to surgery or not, because we know that epidural has to, subdural might go to surgery, right? And if they go to surgery, they might take out a bone flap, right? So this guy, they took out his bone, right? They took out a bone right there, and it's going to have and there's nothing underneath. There's nothing protecting them. So there's bone flap precautions that are done to make sure that we don't put them on their brain. It's like, oh, I can't move my right arm. So let's fix you, sir. Let's get you sat back up in bed. So we want to make sure that we are not pushing pressure on the brain that can increase ICP in of itself. And of course, later, once they heal, they can 3D print it. They used to put it in their abdomen to let it grow there in the meantime, so that it didn't lose its vascularity. And then when they're ready, they took a piece of their abdomen out and put it back on their skull. Okay, I think they got weird hairs after that point. But anyways, we want to get the blood pressure under control after surgery and before surgery. So because blood is blood, and bloods more when you have a high blood pressure. You can't help that, right? So we got to get the blood pressure under 160. 140 to 160 is a good target. If they have a coagulopathy, we got to fix that, right? We got PCC, these are go-to, and other specific agents if needed. Okay, so we only treat seizures. We don't really give seizures to everybody that has a intracranial hemorrhage. If they have a cortical bleed on the cortex, they might give a seizure medications, but really it's up to neurologists and neurosurgery. Okay, and then making sure everything is good. Normal sodium, ICP, O2, blood glucose, all these things need to be normal, so we don't have extension and herniation of our brain, right? So that's our recap of all of our different things we do. And anytime your patient has a change in mentation, we need to get a stat head CT. That's always on the to-do list to make sure if there's any change in LOC, that we have that CT scan available to us. Okay, so that's how we fix intracranial hemorrhages.